Yeah. Now, you've done a tremendous amount of work building this system, this capability. You've added a lot of talented people also,
Yeah,
over the last few years to be able to deliver this high standard of care, which is
yeah,
focused on patient outcomes.
yeah,
And recently, of course, the Alberta Ministry of Health, passed a new bill through the government, Bill 30, which now allows private corporations to be funded through taxpayer dollars. How do you think that's going to impact something like, what Calgary's been able to achieve and set up, or is it too early to tell, or what are your concerns?
yeah. I mean, it's a huge question. In fact, we just had a division-wide chat last week about it. But it's uh, you know, what originally drove it, of course, I believe, was more surgical wait times, and so originally I think it was, how can we deal with surgical wait lists and wait times, and so there was the idea, well, we'll build, maybe we can allow people to build surgical facilities, that and then people could go through those facilities, and but still be, essentially the reimbursement would be the same as if they're going through a public AHS facility, uh, but it would allow the volume to increase. So the wait list could be, and so, and I think a lot of people, certainly if you're waiting for HIP for 2 years, I think that's, I get it. No one wants it. When it's you, it's not routine. It was someone else's routine, right? And so I get that completely. Obviously there are, the most important thing of any of these kind of things are appropriateness and quality, not just cost. And I think you obviously want to put them all together. But uh, so that's on the surgical side. The issue that's come up, of course, for gastroenterology is that. Of course, GI is procedure driven, and so with endoscopy, I don't think the government originally was thinking of endoscopy, but obviously, if you think that a lot of endoscopy, well, most places the endoscopy is done within hospitals, and so if you move that out of an acute care hospital, well, can you deliver that more cheaply? And so now that discussion has started to come up, and also not so much in Calgary, but if you look in other parts of the province, where FIT is the main driver of colonoscopy, the wait times in some parts of the province were really unacceptable, and so the government had put quite a bit of money in to try to fix that, but that was not the case in Calgary ever.
Mm-hmm.
Calgary always had amazing wait times for FIT. It's 6 to 8 weeks to get a colonoscopy. I mean, this is good. You're not going to find that as good anywhere else.
Mm-hmm.
And as I say, cost effective, appropriate, and highest quality. So I think Calgary. I don't even know how it's going to impact Calgary. Obviously, when it's a business proposition, I think people will have a model that may be cost effective. The problem is that we don't want to recreate what happened in Ontario. I think that has been a disaster. I think the problem in Ontario, of course, is that they end up doing a lot of scopes, and because the scopes are done with an anesthetist, often with propofol, they're very expensive. The appropriateness, because they're not driven by the same sort of things like FIT, or they haven't done a kind of a central access and then distribute. It's just free for all, totally free business, free enterprise. So when people are competing for business, of course, then you're going to then appropriateness. The strict guidelines might not be followed, whether or not it's when you should come back for a repeat colonoscopy, should you have a colonoscopy at all, those kinds of things.
Yeah.
And then quality I think, has been a big issue. People have found that that people are coming back with higher frequencies of interval cancers. They end up going for more scopes because they have not been done very effectively at the beginning. So I don't think recreating that in Alberta. I think we'll end up spending more money. People that don't need scopes will get scoped, and I think the quality will be less. So I think the government's aware of that. I know there's been some discussion about making sure appropriateness and quality are maintained. And so I believe as long as its cost, appropriateness, and quality are put into the equation, and they're all viewed as important for the best patient care, and patients are always put in the center of that. I'm very anxious to see how it will unfold. If it's not part of that, then I'm very worried that it won't unfold optimally. Obviously, in places that have been challenged with having patients that come through with FIT, I think that when you have something like a FIT test that's positive, we know that 3 to 5% of those patients are going to have a cancer or pre-malignant condition. They need to be scoped, and waiting, a year with a FIT positive or whatever more, I think that makes me very nervous, and so I think the system has to be better than that. And I think, I think the model in Calgary is a model that could be used in the whole province. Actually, I think that these high throughput, dedicated colon cancer screening centers that have excellent endoscopists and the people that come there are appropriate for being there, and that the quality is that comes out is going to obviously be high because you're dealing with highly skilled endoscopists and appropriate patients. And then some way of following that quality. So whether it's with a system like an EndoPro, or some kind of system to document, so people can then go back and refer back to quality and be able to follow that going forward, I think is absolutely critical to making it cost effective. Otherwise, it'll explode into something where scopes are being done in a lot of places, maybe not appropriately, and the quality will be suspect.
Now, when you look at a FIT positive patient going for a procedure, is there also just an increased risk of, the invasiveness of the therapy that may be required, and why it may be more appropriate to have that in, more of a medical center than a clinic?
What happens in Ontario often is if someone comes and they end up they're FIT positive, so they're appropriate, they come and they get their scope, and then they go, oh, this person's got a big polyp, I'm not very comfortable taking that out. So I'm going to send you to the special center to get this done, or an acute care center. So that person just went through a colonoscopy. Sure, you found that they had a polyp, but now they have to do it all again. Yeah. And so every time you do a prep, and especially, there are risks with everything. Every procedure has a risk. And I think that's a disservice. First of all, you've just doubled the cost, and secondly, you put that poor patient through 2 bowel preps. And I think that for every time someone gets that done, maybe the endoscopist should do a bowel prep. that would stop that. That's a disincentive.
Yes. Yeah. And then also, you mentioned, how do you drive this quality? What were some of the things that you would ensure? Tracking, obviously, whether it be electronic or non-electronic, is critical. The measures of quality are totally critical. And so you're saying in Alberta that would have to be part of the equation if we're going to maintain any chance of quality. But that hasn't happened in many other parts of the country. There's no mandatory quality reporting at all. So that has continued to be a big challenge.
Yeah, and you know what? I think as healthcare budgets get tighter, I think that if people aren't looking at quality and appropriateness, then they're actually spending money on stuff that money should never have been spent for, or they're wasting money. Mm-hmm. And so I think that in the days of flush budgets and everything, I think that probably that was less concerned like that. But now healthcare spending is such a huge driver of every provincial budget, and so I think that you've got that the benefit of having some sort of system of tracking. So for colonoscopy, you want to make sure you're getting the CECM. You want to do a withdrawal time that's going to allow you to see the polyps. And then you have to know that the people doing those colonoscopies are picking up polyps at a rate that tells you that they're excellent, and so those are the minimum standards that you really have to have, and you have to have a system that's designed to make sure people are doing good bowel prep, so you can have a good look around and all that kind of stuff. And so by focusing on quality, actually, the patient outcomes are going to be better. You've got if you're dealing with appropriate patients, if it's quality driven, you're only going to have the best endoscopists doing it. And frankly, if I'm going to get a colonoscopy, I want the best endoscopist that I can get, or at least someone I know that's excellent,
Yeah.
not marginal.
Yeah.
I mean, no one ever says, hey, look, I'm a marginal colonoscopist, but I'd like to do your colonoscopy. Most people would say, you know what, I might just look for somebody else, actually.
Yeah. Well, and I think then there's the whole aspect of cost. And so if you don't have a quality procedure, there's a chance that, there's something missed. That if
Totally.
you're really talking just about cost to the healthcare system, a downstream cancer is a lot more costly to manage and treat than doing
Yeah.
a good screening colonoscopy.
Yeah, not to mention the horrors of having a cancer in a patient, right? So all of the
Yeah.
patient aspects of cancer. So the societal cost and the personal cost,
Yeah.
and then the financial cost, right?
Yeah.
And I mean, I think all of the systems, wherever they are coming more to that. Like if you go to the NHS, I mean, in England, they have very, very important and very strict quality guidelines, and that's across the whole country. And they're mandated. If you don't reach those if you can't do a quality colonoscopy, you're actually not allowed to do them as part of that program. And I just think that is just common sense. That obviously there are some areas in where it's very hard to get people that are as highly trained, but in the end, if you're not doing quality colonoscopies, then the cost to everyone, whether it's a personal cost, a societal cost, or a fiscal cost, is I think it just can't be sustained. Right. And it's just a matter of when, not if.
Yeah.
That it has to change.
Yeah. Now, do you think at all the move on Bill 30 was also financially motivated in that it was a way for the government to save money? You talked about the tremendous economic pressure healthcare is under, the province is under with the economy and so forth. Is that where we get into trouble, where we're looking to save money at maybe the expense of patient care and the outcomes that we really want?
So that's always the balance, right? And I think everyone sees the importance of saving money. I mean, the pot isn't just growing, exponentially anymore. And of course, in Alberta with the oil where it's at, it's devastated the economy. And I don't think anyone can look around and say this economy has not been very, very badly hit. And so I think people want to be part of the solution. And so, however, I think that, and I understand the government, because it's a conservative government, they've always believed in if you can get some sort of more private enterprise into it, then that should breed more savings. And I understand that, and I'm not, I think as long as it's done in a way that where appropriateness and quality are still part of that, and everyone's going to fiddle around with the balance in the end. And I guess if you have no money left in the coffer, then it's irrelevant, right? And if you have $10, then and that's what you're going to spend on the colonoscopy, then that's what you're going to spend, and you're not going to get great quality or whatever, but that's just the way it is. And I think in the end, when you're still working out these balances, because we're just trying to figure out how to do this, I think in a more broad sense, and I don't think anyone feels that it shouldn't be done, because why wouldn't you want the most appropriate people getting a procedure of any sort, whether it's surgery or colonoscopy? And then when you're done, you want to come and go, boy, that scar looks great, I feel great, or boy, that colonoscopy wasn't so bad, And I mean, people come out of the colon cancer screening center and they go, this place is amazing, and so patient satisfaction is extremely high. They know they've had an unbelievably good procedure done by someone who's extremely skilled and qualified. If their polyp is taken out, then they're cured of their potential cancer, and that is what healthcare should be. And so I think as long as people are working in that kind of sphere, I think that whether it's done privately or if it's done publicly or a hybrid thereof, I'm open to hearing what the kind of solutions are. The problem, of course, is that sometimes there's vacuums of information breed fear, and so obviously from the side of the specialists. If you're not hearing information, or you feel like there's a void of information, then sometimes, obviously fear breeds speculation. Speculation often is not correct, and bad, it breeds bad decisions. And so I'm hoping that there will be an open dialogue, and I know there's a lot of strain between physicians and the government, certainly the AMA and the government. But I don't think that means that we shouldn't be sitting down and having some dialogue. And I think cooler heads have to prevail, as long as we keep the patient center and as the most important person, and understand that cost is extremely important, but that appropriateness and quality have to be tied in there to make sure that they're getting the most out of their money. Yeah. I think that there's some good things could be done.
Well, perhaps the good thing is you have an established model for that, and how you communicated and was engaged the broader community, including the government, around the clinical pathway development, and hopefully that can maybe serve as a model to come out with a good solution with this as well.
I'm hoping.
Yeah, you're hoping.